Imagine your eye, well, not just as how you see the world, but maybe as a kind of crystal ball, a direct window showing the immediate critical health of your brain and even your heart.
Hmm.
Today, we're doing a deep dive into an emergency eye condition. Our sources suggest it's far more than just an eyesight problem.
Yeah, that's right.
We're looking at retinal artery occlusion, RAO. It's a diagnosis that, according to some really significant new research, should basically trigger alarm bells, like an urgent search for an incoming stroke or maybe even a heart attack.
It really is like an alarm bell, yeah,
Yeah.
in a very unexpected place.
Absolutely.
And so those listening, just to be clear, retinal artery occlusion, or RAO, it's what we call an ophthalmic emergency. Basically, the artery that feeds blood to your retina, that nerve tissue at the back of your eye, it gets suddenly blocked.
Blocked, okay.
And clinically, yeah, it's often called a retinal stroke. Because the way it happens, the mechanism, it's pretty much identical to a stroke in the brain.
Right, a retinal stroke.
Got it.
Anyway, and the reason we're diving into this today is this, well, massive new study, isn't it?
Exactly. It's a systematic review and meta-analysis published just recently by Wang and colleagues. And it wasn't just a quick look.
Yeah.
They pulled together data from 12 really extensive studies. We're talking nearly 320,000 people involved globally.
Wow, 320,000. That's a huge number.
It really is. And that sheer statistical power, pooling data from almost 1/3 patient records, that's what makes these findings so compelling.
Right.
The researchers' goal was actually quite simple but critical. They wanted to quantify the precise risk of subsequent major vascular events, specifically ischemic stroke and myocardial infarction, MI or heart attack, after someone's diagnosed with RAO.
So our mission today, really, is to figure out if RAO truly is that early warning signal we maybe desperately need. And crucially, can we pinpoint when that risk is highest? Because that could allow for potentially life-saving intervention.
Exactly. Getting ahead of it.
Because when we talk about cardiovascular events, time isn't just money, is it? Time is, well, it's life, or brain function, or heart muscle.
Absolutely. Time is everything in these cases.
Okay, so to really grasp why this particular warning sign is so vital, we probably need to start with the big picture. Just how massive is the problem of cardiovascular disease, CVD, globally?
It's hard to overstate. Honestly, CVD is still the #1 killer worldwide. It accounts for roughly 1/3 of all deaths globally.
A third. That's staggering.
And, you might hope with all the medical advances we've made that number would be going down. But actually, global mortality rates from CVD have increased by about 12.5% over the last decade.
Increased. How? So it's not a problem we're really winning against. It's getting worse.
In terms of overall numbers, yes, it's accelerating. And when you zero in on the two specific events, this study focuses on stroke and MI. They are really the dominant forces behind that trend.
Okay.
Together, stroke and MI, they're responsible for over 45% of all CVD-related deaths. So nearly half.
45%. Just those two.
Just those two. These are the major, sudden, often life-altering, or sadly life-ending events that we desperately need to get ahead of.
Which brings us right to that central problem in acute care, doesn't it? The tyranny of the clock.
Absolutely. We have life-saving treatments for both acute stroke and MI. We know what to do, but whether they work effectively, that's almost entirely dependent on speed. How fast can we act?
And the time limits are just, they're brutal.
Right.
Let's take stroke first. You need to give those clot-busting drugs, thrombolytics.
Right, thrombolysis.
To really make a difference in long-term disability. You've got what? A 4.5-hour window from when the symptoms start?
That's the standard window, yes. 4.5 hours. And every single minute you waste in that window means potentially millions of brain cells are lost forever.
Millions per minute, okay. And for heart attack, MI, it's even faster.
It often is, yes. For the best outcome with an MI, the optimal time window is frequently cited as just 120 minutes, 2 hours.
2 hours.
To get that blood flow reestablished to the heart muscle. When the stakes are that high, 2 hours just evaporates. It feels like no time at all.
But here's the really frustrating part.
Yeah.
Despite knowing these time windows, despite all the public health campaigns know the signs, the system seems to be failing a huge number of patients. There's this, what you call the effectiveness gap.
Yeah, and that gap it's the real tragedy here, I think. Study after study shows that only a small fraction of patients who could benefit actually get these effective treatments within those critical time limits.
How small fraction are we talking?
The range is, frankly, shocking. It's usually between about 9.2% and 29.3%.
Wait, so Best case scenario, maybe 3 out of 10 people who should get the treatment get it in time.
That's right. Best case, sometimes it's less than 1 in 10. Think about that. 7 to 9 out of 10 people are missing that crucial window.
Why? Why is that gap so enormous? It seems like it should be straightforward.
Well, it's complex. It's a whole system issue, really. It often starts with the patient themselves, maybe not recognizing the symptoms right away or delaying calling for help. Stroke symptoms, especially, can be, kind of subtle or confusing sometimes.
Right, not always the dramatic collapse you see on TV.
Exactly. Then you add in emergency service response times, getting to the hospital, transport logistics, and then you hit the emergency department, which is often overcrowded. Triage takes time. Getting the right scans takes time.
So by the time a high-risk patient is actually confirmed and ready for treatment.
Those critical minutes or even hours are often just gone.
Okay, that makes the need for some kind of earlier warning signal incredibly clear.
Precisely. The delay happens at multiple points. And that is exactly why we need an indicator, something that happens before the really devastating event, ideally something that actually brings the patient into a hospital setting for what seems like a different reason.
And that's where RAO, this eye condition, comes in.
That's where it becomes potentially profoundly important, yes.
Okay, so let's connect the dots then. Why would a blockage in a tiny artery in the eye predict a major blockage in the brain or the heart? What's the physiological link?
Because fundamentally, they share the same underlying mechanisms, the same root causes, RAO, stroke, MI. They all commonly involve an artery getting blocked.
Right.
And that blockage is often caused by, well, one of two main things. Either thromboembolism, that's a clot that forms somewhere else, breaks off and travels through the bloodstream.
Like from the heart or the neck arteries.
Exactly. Or it's due to atherosclerosis, the buildup of fatty plaques within the artery walls themselves, which can rupture or narrow the vessel.
And they also share those common risk factors we hear about all the time, like high blood pressure, high cholesterol.
Diabetes, obesity, smoking.
Yes.
The big ones.
And the study confirmed this link in RAO patients.
It did. The source material states that among patients diagnosed with RAO, a really striking 67%. 2/3 already have at least one of these major cardiovascular risk factors identified.
2/3. So the eye isn't having a problem in isolation.
Not at all. The eye is simply reflecting a systemic disease process. It's a process that's already underway throughout their entire vascular system. The plumbing is bad everywhere, essentially.
So the RAO, the retinal stroke, it isn't just a random localized visual problem. It's basically a symptom, a manifestation of the same underlying disease that's also threatening a brain stroke or a heart attack.
Precisely. The eye, in this very specific context, just happens to be the part of the system that experiences a crisis first.
Yeah.
It gives us this opportunity, really, to intervene before that second, potentially much more destructive crisis hits the brain or heart.
It's like the eye becomes this accidental early detection system.
In a way, yes. It bypasses many of the usual delays we see with stroke or MI presentation where people might ignore symptoms. An acute, sudden loss of vision, that usually gets people to seek help urgently.
Right, you don't ignore that.
No. It forces the patient into the healthcare system quickly, which honestly is half the battle won right there.
Okay, that sets the stage perfectly. We understand the context, the life or death stakes. Let's get into the core data from that Wang et al. Meta-analysis. What did they actually find about the link between RAO and the risk of a subsequent stroke?
Well, the link isn't just, hinted at. It's stark, it's clear, it's highly actionable. Patients with RAO face a significantly increased risk of stroke compared to people without RAO in the control groups.
Okay, significantly increased. Let's put a number on that. What was the key statistic?
The number you really need to remember is the pooled relative risk, or RR. For stroke after an RAO, the combined RR was 3.64.
3.64. And remind us what relative risk means in simple terms.
It means that, on average, patients diagnosed with RAO were 3.64 times more likely to have a stroke during the follow-up period compared to similar people who didn't have RAO. Almost 4 times the risk.
Nearly 4 times.
Correct.
And was this statistically solid?
Very solid. The 95% confidence interval, that range, where we're pretty sure the true value lies, was firmly between 2.53 and 5.25. Because that entire range is well above 1.0, it confirms the finding is highly statistically significant. It's not a chance result.
Okay, so nearly 4 times the risk overall. That's huge. But you mentioned earlier the timing was the really critical part.
That's the absolute breakthrough finding here, the part that should really change how clinicians think and act. The study didn't just say if the risk was higher. It pinpointed when it was highest.
This is the aha moment then.
This is absolutely the aha moment. It transforms RAO from just being an indicator of general risk to being an acute, really time-sensitive warning signal. The stroke risk wasn't spread evenly over time. It was overwhelmingly concentrated right after the RAO happened.
Okay, so let's nail down that critical window. When is the danger highest?
The highest risk window was within the first 30 days of the RAO diagnosis, right in that initial month.
The first month.
During that first 30 days, the actual incidence, the rate of new strokes occurring, was 3.56%. That might sound small, but compare it to the baseline risk in the general population over a month, it's dramatically higher. That first month is the period of maximum vulnerability.
And what happened after 30 days? Did the risk stay high?
No, and this is also crucial. It dropped off dramatically, almost like falling off a cliff.
Really?
Yeah. It confirms that the RAO event itself is often a sign of some acute instability, maybe like a shower of small clots, emboli, being released.
Okay.
So between day 31 and day 90 after the RAO, the incidence of stroke dropped way down to just 0.48%.
Wow, from over 3.5% down to less than 0.5%.
Exactly. And then, if you look even further out, from 91 days to 180 days, it dropped a little bit more, down to 0.36%.
So the message is incredibly clear. That first month is everything.
Absolutely. The medical community now has essentially a deadline for intervention. Get the stroke workup done, identify the underlying cause, mitigate that risk, and start treatment within that first 30 days.
And did the individual studies included in the meta-analysis back this up, show this same kind of short-term urgency?
They did. For example, there was a big French study they included from 2018. They looked at a huge health insurance database.
Okay.
They calculated that the incidence of stroke in RAO patients was an incredible 33.1 times higher than in the control group. 33 times.
Goodness. 33 times. That's even more dramatic.
It is, and that particular study sharpened the focus even more. They noted the highest risk seemed to occur specifically within the first 2 weeks after the RAO.
2 weeks, so even tighter.
Even tighter. While the meta-analysis kind of smoothed things out to the 30-day window for a really robust measurement across all studies, the underlying evidence definitely points to intense, immediate danger right at the beginning.
It really is that short-term burst of risk we need to focus on.
Exactly. Even studies that followed patients for a very long time, like one by Rim and colleagues who tracked people for 12 years.
12 years, okay.
They still found an over on increased risk, about 1.78 times higher for ischemic stroke compared to controls over that whole period. But you can see how averaging the risk over 12 years completely dilutes the clinical urgency of what's happening in those first few weeks.
Right, it hides the spike.
It hides the critical spike. The definitive message here is RAO isn't some vague warning about chronic risk down the road. It's an acute, flashing red light. It's telling the doctor that whatever process caused that eye blockage is likely still active and could very well hit the brain next.
And it gives you roughly, what, 720 hours that first month?
Around 720 hours, yes, to act aggressively, to investigate, to treat.
That really reframes the whole approach in the emergency department or the eye clinic, doesn't it? When that RAO patient walks in, they're not just an eye patient anymore. For the next 30 days, they are essentially a stroke imminent patient.
That's a very good way to put it. They need to be managed with that level of urgency.
Okay, so the stroke connection is powerful and time sensitive. Now let's shift gears to the other major event they looked at. Myocardial infarction, or MI. The heart attack risk. Were the findings as clear-cut there?
No, not nearly as clear-cut. This is where the picture gets, well, significantly more complex. It requires a bit more careful interpretation of the statistics.
Okay, so time to put our critical thinking hats on for the MI part. What was the overall finding?
Overall, across all the studies and the entire follow-up periods, the risk of MI did show an upward trend. The pooled relative risk was calculated at 1.38.
So a 38% increased risk trend. But you sound hesitant.
I am, because critically, that result did not reach statistical significance.
Ah, okay. Explain that for us.
Remember the confidence interval, that range of plausible values. For the MI risk, the 95% confidence interval stretched from 0.80 up to 2.4.
0.80. So the lower end dipped below 1.0.
Exactly. For a result to be statistically significant, the entire range has to be above 1.0, meaning we're confident the risk is truly higher than baseline. Because the lower boundary here was 0.80, it means it's statistically plausible that there's actually no increased risk, or even slightly lower risk when averaged over the long term.
So the researchers couldn't definitively say, based on the overall pool data, that RAO significantly increases long-term MI risk.
Correct. For the overall average across all follow-up times, the data was just too variable, maybe too sparse in some studies, to make a strong universal claim. However,
There's always a however.
there is. When they broke it down by time, just like they did for stroke, that familiar pattern reappeared. That acute spike was there.
Ah, okay. So the timing aspects was similar for MI.
It mirrored the stroke pattern almost perfectly. The risk for MI was also highest within the first 30 days after the RAO.
And what was the incidence then?
In that first month, the incidence of MI was 0.88%. Again, higher than you'd expect in the general population over just 1 month.
So there is some kind of acute cardiovascular instability affecting the heart right after the RAO event, too.
It certainly seems that way. And just like with stroke, the risk then dropped sharply. Between 31 and 90 days, the MI incidence fell way down to just 0.09%.
Okay, so there's definitely an acute hit, even if the long-term picture is murky.
Precisely. This acute spike strongly suggests that whatever systemic issue triggered the RAO, maybe inflammation, maybe small emboli, is also causing some immediate but perhaps more temporary vulnerability in the heart as well, even if the long-term disease progression for MI follows a different path.
And this ambiguity, this difference between the short-term spike and the uncertain long-term risk, does that explain why the older research on the RAO-MI link was so kind of contradictory?
I think it explains a lot of it, yes. You had older studies, like one by Bruno and colleagues back in 1995, that looked long-term and found no significant difference in MI risk.
Right.
But then you get more recent, large studies, like one by Wei et al. In 2023 that reported a significantly higher risk. They found an RR of 1.72 over a 1-year follow-up.
So different studies, different results.
Yeah.
How did this meta-analysis help clarify that?
They dug deeper with what's called subgroup analysis, and they found something really interesting when they narrowed the time window even further, looking at just the first 2 weeks after RAO.
Okay, that really tight window again.
Yes, in the first 2 weeks, the relative risk for MI was a massive 3.00, 3 times the risk.
3 times, just in the first 2 weeks.
Just in the first 2 weeks. This is fascinating because it really confirms that those longer follow-up studies, the ones looking over a whole year or more, they're essentially averaging out that initial 2-week crisis period with the later months of much lower risk.
So they're washing out or obscuring that critical, highly elevated acute risk signal.
Exactly. It gets lost in the long-term average. And this sort of fragility of the MI data was really highlighted in what's called the sensitivity analysis. It's a technical step, but important for understanding the data's reliability.
What did that show?
They basically reran the numbers multiple times, each time removing one of the individual studies to see if it dramatically changed the overall pooled result.
Okay, testing how much influence each study had.
Precisely. And for the MI findings, the results were highly sensitive. They were, well, brittle.
Brittle, how so?
For instance, when they took out that large Wei et al. Study, the overall pooled RR for MI suddenly jumped up from the non-significant 1.38 to a much higher 2.16.
Wow, quite a jump.
Conversely, removing some other, maybe smaller or slightly different studies, caused the overall RR to drop down to 1.12, which was statistically significant but much lower.
Okay, so the overall MI number bounces around a lot, depending on exactly which studies you include.
It tells us the conclusion about MI risk is highly dependent on the specific mix of patients and study designs included. We can be pretty confident about that short-term spike in the first 2 to 4 weeks, but for the longer-term elevated risk, we probably need more consistent large-scale research specifically focused on MI after RAO.
Okay, that makes sense. So recapping, a very strong, statistically solid, near 4-fold increased risk for stroke, peaking in the first month. But for MI, a statistically volatile picture overall, though with a definite significant spike in risk right at the beginning, especially in the first 2 weeks. This difference demands an explanation. Why? Why the discrepancy physiologically?
The key difference likely lies in the primary mechanism that usually causes RAO in the first place.
Oh.
RAO and ischemic stroke very often share that common cause we talked about. They're frequently acute embolic events.
Right, the traveling clots.
Yes. Small bits of cholesterol or calcium or clot breaking off from plaques, often in the carotid arteries in the neck or sometimes from the heart itself, maybe due to atrial fibrillation. These little emboli travel downstream.
And they can easily travel up into the small arteries of the retina or the brain.
Exactly. It's a sudden thromboembolic pathway. Now, MI A heart attack, while it absolutely shares the same underlying risk factors, the
Mm.
hypertension, the diabetes, the cholesterol, it more often results from the chronic progression of atherosclerosis, specifically within the coronary arteries, the arteries supplying the heart muscle itself.
So plaques slowly building up in the heart arteries over time, rather than necessarily a clot traveling to the heart from somewhere else.
More often, yes. The plaques build up, then maybe one ruptures, causing a clot to form right there, blocking the coronary artery. So while emboli can cause MI, the more typical pathway involves this chronic local progression within the heart's own vessels. It's often a different primary mechanism than the acute embolic shower that frequently causes RAO and stroke simultaneously or sequentially.
Okay, so the RAO, being an acute embolic event itself, is like a perfect preview or warning signal for the next likely acute embolic event, the stroke.
That seems to be the strongest connection, yes.
Whereas the link to MI, while definitely present in that acute unstable phase right after the RAO, is maybe less reliable as a long-term predictor because the typical heart attack often develops through a slower, more chronic process.
That appears to be the case, based on this analysis. However, and this is crucial, given that very real, statistically significant spike in MI risk in the first 30 days, even if the long-term data is ambiguous.
You still have to act on that immediate risk.
Absolutely. A comprehensive, immediate cardiovascular assessment, including looking at the heart, remains the only responsible course of action for every single RAO patient. The eye is still shouting about system-wide instability, even if the biggest immediate threat is the brain. You check everything.
Okay, that's a really important clarification. Check everything, especially in that first month. Now, we've established RAO as a critical warning, but we need context. How does this stroke risk after RAO compare to what's considered the classic warning sign, the gold standard, a transient ischemic attack, or TIA?
Right, the TIA, often called a mini stroke. That's historically been the predictor that really gets everyone's attention, signaling a very high risk of a major stroke soon.
So how do they stack up, RAO versus TIA?
When you compare them directly, the risk of a major stroke following an RAO is generally lower than the risk following a TIA.
Lower. Okay. Could you give us a sense of the TIA risk numbers just so we can appreciate the difference in scale?
Yeah, the TIA numbers are truly sobering. For patients who've had a TIA, the urgency is immense. The risk of having a major disabling stroke can reach about 5.2% within just 7 days of the TIA event.
5% within a week.
Wow, and the risk keeps climbing. Depending on the patient's specific risk factors, it can range up to nearly 40%, 39.2% within 90 days, so within 3 months.
Almost a 40% chance in 3 months? That's
Right.
incredibly high.
It is. Long-term, the one-year risk after a TIA is often quoted somewhere between 14.5% and 21.4%. Huge numbers.
Okay, so compare those massive TIA risks, 5% in a week, maybe 20% in a year, to the RAO risk, which was about 3.5% incidence in the first 30 days. TIA is clearly the much stronger predictor.
It is significantly stronger.
Yeah.
And again, the reason likely comes back to the underlying physiology.
How so?
A TIA, by its very definition, involves a temporary blockage within the brain's circulation itself. It often affects larger arteries supplying the brain, or it stems from major sources of clots in the heart, like atrial fibrillation.
So the location and the cause are almost identical to a major stroke, just temporary.
Exactly. The TIA's origin story, its etiology, aligns almost perfectly with what causes the subsequent major ischemic stroke. It's like a dress rehearsal.
Whereas RAO, as we discussed, is a blockage in a much smaller vessel, in the eye's microvasculature.
Precisely. RAO involves the central retinal artery, or one of its tiny branches. These are end arterioles, very small vessels. So while both RAO and TIA signal systemic vascular disease is present,
Right.
the TIA's location happening right there in the cerebral circulation, often involving larger clot sources, just makes it an inherently stronger, more direct, more proximal warning signal for a major brain event.
Okay, that makes sense. But, and this seems important, the authors of the meta-analysis really stress this point. Even though the RAO-related risk is lower than the TIA-related risk, it is still substantially elevated compared to the general population baseline.
Absolutely. Critical point.
Yes.
The overall risk of having any major vascular event, whether it's a stroke, an MI, or even vascular death, is significantly increased after an RAO. It demands aggressive investigation and intervention. The patient might not be facing the immediate sky-high risk level of a TIA patient, but they are absolutely in a high-risk category compared to average.
So not TIA level risk, but definitely high risk.
Got it. That's the key takeaway. However, We also need to be a little cautious about taking these numbers as absolute gospel, because conducting these huge population studies, especially ones using administrative databases like health records or insurance claims, always comes with inherent challenges, methodological limitations.
Right. What kind of challenges can creep in and potentially skew the results, even when you're looking at hundreds of thousands of people?
Well, a primary issue is always how accurately and consistently the initial diagnosis is made. It's called case ascertainment.
How sure are we that everyone labeled RAO truly had an RAO?
Exactly. And the review highlighted a perfect, really stark example of this. There were two very large studies included, both using the National Health Database from Korea. Huge populations.
Okay, same data source.
Same data source. One study by Park and colleagues found a massive 21.5-fold increase in the risk of stroke within 1 month after an RAO diagnosis. Just huge.
21 times.
Yeah.
Right. And the other Korean study?
The other study by Chang and colleagues, using essentially the same national data pool, found no statistically significant association between RAO and stroke at all. Zero link.
How is that even possible? Two giant studies, same population source, wildly different results. One finds 21 times the risk, the other finds no risk.
It seems baffling, right? But the authors of this meta-analysis suggest the difference might boil down to how the RAO cases were identified in each study.
The diagnosis method again.
Yeah. The Park study, the one that found the huge risk, relied on validated established ICD codes. Those are the standardized billing and diagnostic codes that hospitals and doctors use, which are generally quite reliable for confirmed diagnoses.
Okay, so they use confirmed coded diagnoses.
Whereas the Chang study, the one that found no link, often relied on diagnoses that were initially recorded in an outpatient clinic setting or during the initial emergency room visit.
And those initial frontline diagnoses, they can sometimes be wrong, especially for something specialized like RAO.
They can be notoriously less reliable, yes.
Yeah.
Think about it. Someone comes into a busy ER with sudden vision loss. It might initially be coded as RAO, but after a full workup by an ophthalmologist later, maybe it turns out to be optic neuritis or a complex migraine or something else entirely.
Right.
So if a significant chunk of the patients initially labeled RAO in the Chang study actually had a different condition, their RAO patient pool would be contaminated with lower risk individuals. That would dramatically dilute the apparent stroke risk associated with true RAO.
I see. So that subtle difference in how you define your cases, based on initial suspicion versus confirmed diagnosis, can create this massive chasm in the final results.
It really can. And then you have the flip side of that problem. Studies done at single, highly specialized academic hospitals. They might have perfect diagnoses, but suffer from selection bias.
How so?
Well, there was one study mentioned, Lisinski et al., from a single university center. They meticulously confirmed every RAO diagnosis with detailed eye exams, angiography, the works, top-notch confirmation.
Okay, so very accurate diagnoses.
Yes, but they found a very low subsequent stroke incidence, actually similar to the general population. The problem is who gets treated at a major university referral center.
Probably people with good insurance who live nearby who are maybe generally healthier or more proactive about their health to begin with?
Exactly. They likely included only the best patients, the ones who were healthy enough, informed enough, and resourced enough to navigate the system and follow up at a specialized center. They might have inadvertently excluded the sickest patients, or those from lower socioeconomic backgrounds, the very people who might actually be at the highest risk for subsequent stroke.
So that selection bias could artificially lower the observed risk in their specific group.
Precisely. It makes their results less generalizable to the broader population of all RAO patients. So you have these pushes and pulls in the data based on methodology.
Okay, this is complex. But synthesizing all of this, the strong stroke link, especially in month 1, the weaker but still acute MI link, and acknowledging these methodological challenges, what does it all boil down to? What are the immediate actionable clinical recommendations when a patient is diagnosed with RAO today?
The evidence, particularly from this large meta-analysis, strongly supports the conclusion that RAO should not be treated as just an isolated eye problem, period. It demands an urgent systemic response. And this aligns perfectly with guidelines already put forth by major bodies like the American Academy of Ophthalmology and the American Heart Association.
So what does that response look like?
It means immediate evaluation and, crucially, referral to a stroke center or a specialized vascular neurology service right away.
So the eye doctor diagnoses it and immediately gets the stroke team involved.
Yeah.
It requires collaboration.
instant collaboration between ophthalmology, neurology, and potentially cardiology as well.
Right.
And the study specifically highlights several critical actions that really need to happen within that dangerous first 30-day window.
Okay, what are they?
First, the patient absolutely should undergo advanced imaging of the blood vessels supplying the brain. Typically, that means magnetic resonance imaging, MRI, and magnetic resonance angiography, MRA, while they are still hospitalized or very shortly after.
So treat the eye, but immediately look upstream at the brain's plumbing.
Immediately look upstream, exactly. Check for any existing blockages, areas of narrowing, or sources of potential clots that could cause a stroke.
Okay, that's number one. What about after they leave the hospital?
Surveillance is absolutely paramount. The second key measure is meticulous monitoring. Patients and their families need to be educated about the warning signs of stroke and MI and told to seek help immediately if anything occurs.
Okay. Vigilance.
And third, for patients who already have known high-risk factors, maybe they're a smoker, have poorly controlled diabetes or known carotid artery disease.
Right, the usual suspects.
Physicians need to be really aggressive about considering medications to stabilize things. That means seriously evaluating antiplatelet drugs like aspirin or clopidogrel, and sometimes even anticoagulant therapy, the stronger blood thinners.
To try and prevent new clots from forming or traveling.
Exactly. And finally, what about the heart? Given that definite, even if short-lived, spike in MI risk.
Yeah, what's the recommendation there?
We can't ignore that acute risk. The recommendations include implementing early MI detection measures while the patient is being evaluated, even if they have no chest pain or other heart symptoms.
Proactive heart checks.
Yes. Things like getting an electrocardiogram, ECG or EKG, and checking cardiac biomarkers in the blood like troponin levels, which can indicate heart muscle strain or damage. Basically, that first 30 days becomes a comprehensive triage period for the patient's entire systemic vascular tree, brain, heart, everything.
Wow. This deep dive really does force a fundamental reevaluation of how we handle an ophthalmic emergency like RAO. It's not just about saving vision anymore. This event in the eye is effectively a high-stakes, short-term countdown clock for a potential stroke.
That's precisely the takeaway. To summarize the core findings again, RAO is a substantial, clearly measurable predictor of subsequent stroke. The overall relative risk is high, around 3.64.
Nearly 4 times the risk.
But the most clinically vital piece of information is the timing. That risk isn't spread out, it peaks dramatically, almost entirely concentrated within the first 30 days after the RAO diagnosis.
And the MI link.
Statistically, it's, well, messier when you average it long-term. But the data still clearly shows an acute short-term spike in MI risk right after the RAO as well, indicating systemic cardiovascular instability.
So the bottom line for clinicians.
The bottom line is that immediate aggressive cardiovascular assessment and close collaboration between eye doctors, neurologists, and cardiologists is unequivocally warranted for all patients diagnosed with RAO. No exceptions.
The eye is not an island.
Not at all. The true implication of this research is that the eye often serves as the first, most visible battleground where systemic vascular disease declares itself. Recognizing that connection allows us to seize that small but incredibly precious window of opportunity that first month to intervene and potentially prevent a devastating stroke or other major event.
Which brings us to our final provocative thought for you, our listeners, to mull over. RAO itself, thankfully, is relatively rare. And as we discussed, that rarity made it challenging for these studies to gather huge numbers, especially for the MI analysis. But if RAO is the end result, the full blockage, is there a warning before the warning? Could we detect signs before the retinal artery fully occludes?
That's really the holy grail of preventative medicine, isn't it? Right now, we're reacting to the retinal stroke after it happens. But what if we could use advanced technology, maybe AI-powered analysis of routine retinal scans during annual eye checkups?
Looking at the tiny blood vessels in the back of the eye?
Exactly. Could we map and analyze that incredibly detailed network, the retinal microvasculature, and detect subtle warning signs long before a full blockage occurs?
What kind of subtle signs are we talking about? Like tiny hemorrhages, changes in how twisty the vessels are?
Increased vessel tortuosity, yes. Or changes in the caliber, the width of the tiny arteries compared to the veins, subtle narrowing, maybe early signs of plaque or vessel wall thickening, things you might only see with high-resolution imaging and sophisticated analysis.
So if we could reliably identify these very early, subtle abnormalities in the retina.
And critically, if we could correlate those specific patterns with known systemic risk factors and ultimately with future risk of stroke or MI.
They might provide an even earlier, more refined screening method, targeting high-risk people before they even have an RAO, let alone a stroke.
That's the potential. Moving from reacting to the RAO towards proactive prevention, identifying the systemic risk bubbling under the surface years earlier just by looking closely at the back of the eye during a routine exam.
That would be revolutionary. Turning the standard eye exam into a frontline screening tool for the biggest killers, stroke and heart disease.
It would fundamentally change how we approach screening and managing cardiovascular disease globally, a truly fascinating and potentially life-saving area for future research.
Indeed. A powerful reminder of the intricate connections within our bodies and the secrets the eye might hold. Thank you for joining us for this deep dive.
My pleasure. Until next time.